There's controversy in the area of the efficacy of aspirin for primary prevention. And there's also a question about the efficacy of immediate release or standard aspirin in patients who have high platelet turnover. So particularly patients who have high platelet turnover would be patients who have diabetes, patients who've had heart attacks, patients who have stents, patients who've had surgery. These are certain subgroups of patients who have high platelet turnover. So in those patients with high platelet turnover, if the new platelets get generated in the circulation, after you take immediately release aspirin, those platelets are basically naked. Their COX-1 is not clothed with aspirin, and they're vulnerable to reacting and becoming activated and participating in thrombus formation in the coronaries, theoretically. So the exciting thing about this new formulation of aspirin is it may be associated with better GI tolerability and therefore better compliance as compared to standard dose aspirin. With this new formulation of aspirin, an extended release formulation, the aspirin is released in an extended form in the circulation. So we tested the hypothesis that this aspirin formulation provides a stable antiplatelet effect over 24 hours in the patients with high platelet turnover. And our findings were that we had two primary endpoints. We looked at collagen-induced aggregation and we looked at arachidonic acid-induced aggregation at 1 hour after the last dose and at 24 hours after the last dose. And our definition of failure would be an increase in aggregation of 15%. And so what we found was that indeed, for our co-primary endpoint, the platelet function did not change over 24 hours. So we established with aggregation that there was a stable antiplatelet effect from this new formulation of aspirin. Moreover, we looked at thromboxane B2 in serum and demonstrated that indeed there was stability in the levels of thromboxane B2 in the serum. And the final thing we looked at were metabolites of thromboxane B2, 11-dehydrothromboxane B2 in urine, and demonstrated with a third method that the effect of aspirin was stable. This is a dose of 162.5 milligrams of aspirin in this formulation. We also looked at 325 milligram formulation of Durlasa in a subgroup of the patients who had high platelet turnover and demonstrated that with the 325 milligram dose, you actually lower platelet aggregation even more than you do with the 162.5 milligram dose. We've shown this before in prior work that we've presented, studied in the ASPECTS study, was published in Circulation in 2007. We showed that 325 milligrams of aspirin provides a more potent antiplatelet effect than 162 when you look at collagen. We did find that with the higher dose of Durlasa, you get even lower platelet reactivity when you look at collagen-induced aggregation, and the serum thromboxane levels also fell as well. This drug is approved by the FDA, and it would be used particularly in patients the physicians concerned of would have high platelet turnover. So in our population of patients, these were patients with diabetes and overt coronary disease, vascular disease, or cardiovascular risk factors. So it would be in this population, and indeed in this population we identified markers of high platelet turnover in about 60% of the population. This would be a particular patient that you'd be interested in. But also in any other patient who, for secondary prevention, who may not have diabetes, if you want to ensure a stable antiplatelet effect, and I think we've established unequivocally that this formulation provides a stable antiplatelet effect, and I've told you we've looked at it through multiple metrics. One other intriguing aspect of this study is that we actually looked at a marker of endothelial function, and we showed that when you go from 162 of Durlasa to 325, you also improve endothelial function. Well, there is some concern with higher doses of aspirin, less GI tolerability. That's another aspect of this drug that is going to be investigated. We're going to embark upon a study looking at whether this agent is associated with better GI tolerability than standard dose aspirin. In patients who have intolerance to standard dose aspirin, we're going to give them Durlasa and see what happens to their GI intolerance, because the formulation and the gradual release of aspirin may be associated with a better prostaglandin, good prostaglandin sparing effect. I think this unequivocally answers the question of whether this formulation of aspirin provides a stable antiplatelet effect. I still think there's a lot of question about the utility of aspirin for primary prevention, and I think we need to do better to tailor aspirin therapy based on objective measures of whether the patient is prothrombotic or not through more sensitive blood testing, and we need to go beyond just looking at demographic variables. We're going to look at the GI tolerability issue in patients who are intolerant to regular aspirin. There will be a study where these patients will be treated with Durlasa. We're going to do that study at Inova Heart and Vascular Institute. In that study, we're also going to assess pharmacodynamics and pharmacokinetics as we did previously. And the ultimate goal would be to do a large-scale clinical trial to see whether this stability of platelet inhibition translates into a better clinical outcome than you get when you use just regular aspirin. The other thing is that that should be considered is a comparison of this agent to regular aspirin to see whether there is indeed a better pharmacodynamic profile with this agent as compared to standard aspirin.